All right, let's get right into it. When you have to secure an airway in a critically ill patient, those few minutes right before you intubate are everything. We're talking about pre-oxygenation, and it's all about buying yourself more time. Today, we're going to put two major techniques head-to-head, the classic oxygen mask versus non-invasive ventilation, or NIV. So picture this. You're in the ED, you're in the ICU, your patient is crashing, and you've made the call, we have to intubate. From the exact moment you push those induction drugs, a clock starts ticking. You have a very, very small window of safe apnea before their oxygen levels just completely bottom out. So the real question is, when you're looking at that airway, have you done everything you possibly can to make that window as long as possible? I mean, the patient's life literally hangs in the balance for the next few minutes. Let's really break this down. This apnea window, it's the time from when the patient stops breathing to when their oxygen saturations plummets to dangerous levels. Our entire goal with pre-oxygenation is to just jam their lungs full of as much oxygen as we can to stretch that window out and prevent a total disaster. And look, this is not some rare once-in-a-career problem. Even with our best efforts, severe hypoxemia happens in 10 to 20% of all emergency intubations in the ED and ICU. Think about that. That could be as many as 1 in 5 patients. That number is just, it's shockingly high. Let's be absolutely crystal clear about what we're up against here. Peri-intubation hypoxemia isn't just a number dipping on the monitor. No way. It's a critical, life-threatening event that directly cranks up the risk of the two things we all dread, cardiac arrest and death. This is exactly why great pre-oxygenation isn't just a nice thing to do. It is an absolute must. Okay, so let's look at our first contender. This is the tool that's in every crash cart, on every single unit, the standard oxygen mask. For most of us, this is the foundation of pre-oxygenation. You know the drill. Whether it's a non-rebreather or a bag valve mask, the idea is pretty much the same. Deliver a ton of high-flow, high-concentration oxygen to the patient while they're still breathing on their own. It's simple, it's fast, and it's everywhere. Now, these steps are basic, but every single one of them is critical for this to work. It all starts with positioning, right? How to the bed up, then get the monitors on, crank that oxygen to flush rate, and maybe most importantly, get that perfect two-handed CE grip to get a rock-solid seal. And you're doing all this for 3 full minutes before you even think about pushing those meds. So what's the bottom line on the mask? It's simple, it's cheap, and it's fast. And when you have that perfect seal, it can be really effective. But here's the catch. Its biggest strength is also its biggest weakness. It is completely dependent on how good your technique is and, what the patient's face shape is like. Now, let's bring in the second contender. This is a more advanced approach that really builds on those basics, non-invasive ventilation, or as we all call it, NIV. So here's the game changer. NIV doesn't just pour oxygen onto the patient's face. It delivers it under pressure. It uses what we call PEEP, or a positive end expiratory pressure, to actively pop open all those collapsed little air sacs in the lungs. That creates way more surface area for oxygen to get in. The setup here looks really familiar at first glance. Positioning, monitors, getting a tight-fitting mask. But the huge difference is in step 4. We're actually setting up a ventilator. Yeah, we're dialing in 100% FiO₂, but we are also setting an expiratory pressure, that's the PEEP or EPOP, of at least 5, and an inspiratory pressure, the IPOP, of at least 10. This is active support, not just passive oxygen delivery. Okay, let's just pause for a second, because this is the whole thing right here. The oxygen mask is a passive system. It just sits there, and it's completely up to the patient to pull that oxygen in. NIV is an active system. It uses pressure to physically stent open the airways and help push oxygen into the lungs. This one difference is the reason for all the data we're about to see. So, we've got a simple, passive tool versus a more complex, active one. Which one actually does a better job when a patient's life is on the line? All right, let's turn to the evidence and see what the clinical trials actually say. And wow, the difference here is not subtle. It is stark. We're talking about severe hypoxemia and SpO2 below 80%. One trial found that happened in 46% of patients with just a mask, almost half. With NIV, just 7%. Another trial, similar story, 13% versus 6%. The data is it's screaming at us. NIV is significantly better at preventing a life-threatening desaturation. Okay, but I know what you're thinking. Is it safe? We all worry about blowing air into the stomach, causing aspiration. Well, this data is incredibly reassuring. Looking at a whole combination of adverse events, the mask group actually had a rate of over 41% compared to under 18% for the NIV group. And the big one, aspiration, was basically the same and low in both groups. So NIV seems to be not just more effective, but actually safer overall. And there's another benefit down the line too. Better preoxygenation just makes the whole procedure go smoother. One study actually showed first-pass success jumping from 73% with the mask to over 81% with NIV. It just makes sense, right? A better oxygenated, more stable patient is an easier patient to intubate. Okay, so the evidence seems pretty darn compelling, but what does this actually mean for you and me at the bedside on our next shift? Let's boil all this down into some clear, actionable takeaways. So here's what this changes. For our highest risk patients, the ones who are already super hypoxemic, NIV should probably be our new default strategy. That's a big deal. But here's what it doesn't change. The oxygen mask is still an absolutely vital tool, and none of this advanced tech replaces the absolute fundamental need to be a master of the basics: positioning, mask seal, and jaw thrust. So the bottom line is crystal clear. The data is strong. Compared to a mask, NIV leads to less severe hypoxemia, it's linked to fewer bad outcomes, and it might even help you get the tube on the first try. You should be strongly considering it for your sickest patients, especially those with severe hypoxemia, obesity, or bad lung disease, where that little bit of PEEP can make all the difference in the world. And that brings us to the final question, the one I want you to take with you on your next shift. Based on this evidence, who's it going to be? Which of your patients will you decide to use NIV on for pre-oxygenation? Because thinking about it now is how we turn this data into better outcomes when it really counts.